Okay, let's present an interesting case of ovarian hyperstimulation syndrome. This was a 30-year-old female presenting to the ED with abdominal pain. She was a G1P1 and states that about 3 days ago, she had an egg retrieval out of state and had 2 injections of an unknown hormone. She says everything went well as far as she knows. Today, she has abdominal pain, shortness of breath, and bloating. On exam, she's tachycardic. She has soft blood pressures, but is not hypotensive. She is healthy appearing and no distress. Her abdomen is distended, non-tender, and non-peritoneal. What we see here are bilaterally enlarged multicystic ovaries, which are quite dramatic. There is significant ascites or peritoneal fluid noted as well. And this is all seen on the transabdominal view. Highly abnormal ultrasound. Okay, let's talk about ovarian hyperstimulation syndrome. It is essentially an iatrogenic complication of assisted reproduction technology. It features cystic enlargement of ovaries and fluid shift into the third space, secondary to increased capillary permeability and ovarian neogenesis. The occurrence is dependent on administration of HCG. It can be deleterious, and fatal cases have been reported, thought to be mediated by production of angiogenic molecules such as VEGF. The incidence of moderate cases is about 3 to 6%, and severe cases is much more rare. There are essentially 2 forms. The early one, as in the case with our patient, occurs within days of HCG administration and an exaggerated response, and then the later phase related to secretion of placental HCG. And those ones are more severe and long-lasting. Risk factors include young age, history of sensitivity to gonadotropins, history of OHSS, and PCOS. Clinical features include abdominal pain, nausea, vomiting, ascites, distension, and peritonitis. Patients can be hypotensive, hypovolemic, and dyspneic. They can have an increased risk of VTE and severe electrolyte dysfunctions and acute renal failure. And it can basically be classified into 3 buckets of mild, moderate, and severe. Prevention, essentially you give albumin or start solution to increase plasma oncotic pressure. You can give gonadotropin releasing hormone antagonists to help prevent. Metformin has been studied, cabergoline, and then NSAIDs and aspirin. As far as workup in the emergency department goes, you got to get the basics: serum HCG, CBC, BMP, coags, and then of course an ultrasound. You can consider other stuff depending on the symptoms, like an echo and a chest x-ray, and then DIC labs and reproductive labs. Treatment in mild cases is basically supportive with pain control and oral fluids, and avoid any activity or intercourse until the patient starts to improve. And those patients can be treated as an outpatient. Moderate cases require bed rest, IV fluids, potentially paracentesis, VTE prophylaxis, serial ultrasounds and labs, and close monitoring of intake and output. Severe cases require a pleural drain and often admission to the ICU with very close balance checks and electrolyte corrections. Hypovolemia is a real problem, so they require hyperosmolar agents. And the clinical endpoint of improvement is the cysts are shrinking on 2 consecutive ultrasounds. Clinical symptoms improve, and improvement usually starts in 2 or 3 days with complete resolution by 2 weeks. In the case of our patient, the formal ultrasound confirmed the diagnosis of OHSS. She was injected with clomiphene. She was admitted to the OB/GYN service, placed on leuprolide and letrozole. She had low urine output on initial inpatient management, despite IV fluids and albumin, so she ended up in the ICU on the next day. She had initial paracentesis performed, and then an indwelling catheter was placed for serial paracenteses. She was started on doxycycline. She was only in the ICU for a couple days and discharged home on day 9 in stable condition. She did very well. So 3 key points about ovarian hyperstimulation syndrome. OHSS is an iatrogenic disease characterized by enlargement of the ovaries and a fluid shift into the third space. Management primarily revolves around maintaining intravascular volume and adequate urine output. Patients can become critical and require ICU admission due to disease progression, instability, development of ARDS, ARF, and PE, among others.